We are live now.
Yeah, thank you. So good evening and welcome you all for this virtual postgraduate training program of API ICP South Zone, South Mid Zone panel. We have with us this week Dr. Geeta Madam, who's a professor of medicine from Department of Medicine, Cornell College. Welcome you, Madam, being the
Good evening,
faculty
sir.
for today's program. Good
Good
evening,
evening.
Madam.
Good evening.
And we have with us Dr. Bharati Raja, the Senior Assistant Professor from Department of Medicine, Cornell College, with us. Good evening, Dr. Bharati Raja, and welcome you for this
Good evening,
teaching
sir,
program.
ma'am. Good evening, sir, ma'am.
Yeah. And we have with us Dr. Deepak is going to present the case of splenomegaly. He is a postgraduate from Cornell College, Department of Medicine. Welcome, Dr. Deepak. The first half of the session is going to be chaired by our faculty is going to be Dr. Geeta Madam and Dr. Bharati Raja. Second half is going to be presented by Rishi Kumar. He's a postgraduate from Department of Medicine, Cornell College. Interesting effects of anemia, and is going to be coordinated or means chaired by or moderated by Dr. Geeta Madam and Dr. Dhanalakshmi, who's a professor of pathology, is going to join soon for this evening. So welcome you all for this and requesting the faculties to take over the further proceedings of this evening. Over to Madam and Dr. Bharati Raja to take over the further proceedings. Thank you.
Thank you, sir. We'll start.
Shall I start, ma'am?
Yeah, please.
Good evening, sir. Good evening, ma'am. Mr. Raju, 66-year-old male, a native of Tirupur, was working in a lorry shed as a daily wager. Came with the chief complaints
small
of
correction. Sorry, Deepak. Here, a small correction, though you have just started. See, I was going through. There's no word called wager. See, wager is not wager. Of course, there is a word called wager, but you know the meaning of wager is somebody who's doing a betting. That is only wager. So please, because I've seen many of you using this, so I just wanted to tell it so that it reaches out to many people. Daily wage earner. Correcta solunga. Okay.
Mr. Raju, 66-year-old male, native of Tirupur, was working in a lorry shed as a daily wage earner. Came with chief complaints of abdominal distension, easy fatigability, loss of appetite, and loss of weight for past 2 months. Presenting complaints, patient was apparently normal 2 months back and presented with complaints of abdominal distension for past 2 months, which was gradual onset, progressive in nature, with a localized swelling on left upper abdomen, which was not decreased on lying down, sometimes associated with...
See, I have a doubt here. You are telling abdominal distension with localized swelling on left upper abdomen. So are you talking of an abdominal distension which is presenting along with the left upper abdomen swelling, or what do you mean by that?
Yeah, yes.
See, do you understand what you're telling? Complaints of abdominal distension for 2 months with localized swelling on left upper abdomen. You mean to say that both are coexisting? How can it be possible? Abdominal distension with localized swelling on left upper abdomen. Is that so?
The abdominal distension
or are you
was
talking
present.
of a swelling?
Swelling, the patient himself told
so you're
that
saying that there is both abdominal distension, overall distension, along with the localized swelling in the left.
No, ma'am. It's for in the left hypochondrium, umbilical, covering umbilical and lumbar regions only.
No, that's
mainly
okay.
the left
So,
lumbar.
So you specify that he has noticed a swelling in the left upper abdomen over the past 2 months, which has been progressive. I think that's the way you should say, because you're confusing both.
Okay.
The
complaints of localized swelling on left upper abdomen, which is progressive in nature for past 1 month, sometimes associated with diffuse pain and not associated with any pulsations. Complaints of easy fatigability on doing his regular work in the form of lifting same amount of weights which he could do easily before, and his duration of work also reduced to the extent that he stopped going work on arrival. Complaints of unintentional significant loss of weight and loss of appetite, and decreased food intake due to early satiety for past 3 months. Complaints of bilateral swelling of legs for past 2 months duration, which was gradual onset, progressive in nature, which was initially relieved by rest, now persistent, associated with dyspnea and exertion, and not associated with PND, orthopnea, facial puffiness, or frothiness of urine.
Now, you mean to say that initially relieved by rest? You mean to say that the swelling of legs got relieved by rest?
Yes, ma'am. Actually, he told that initially there was mild swelling while walking, and by taking rest, it decreases.
Okay.
History of fever for 1 day, 10 days back, just low grade, intermittent, not associated with chills and rigors, for which he got it treated locally and not associated with the night sweats. No history of nausea, vomiting, hematemesis, constipation or obstipation. No history of bleeding gums, epistaxis, melena or hematochezia. No history of yellowish discoloration of eyes or high colored urine, abdominal pain or pleuritis. No history of dysphagia, heartburn or dyspepsia. No history of chest pain, syncope, palpitations or sweating. No history of oliguria, burning maturation, hematuria or dysuria. Past history. No history of previous similar complaints or previous admissions in the past. Known case of pulmonary tuberculosis for which he completed treatment before 15 years. Not a known case of systemic hypertension, diabetes mellitus, CAD, congestive cardiac failure, a known kidney disease or liver disease, a pulmonary, or any thyroid disease. No history of previous surgeries or drug intake. Personal and family history. Consumes mixed diet. Known smoker for 40 years. Stopped smoking before 2 years. Was a heavy smoker with a smoking index of 800 and 40 pack years. Not a known alcoholic. No history of any malignancy in his family members or first degree relatives. Summary: 66-year-old male was a chronic smoker, a non-alcoholic with a history of pulmonary tuberculosis, was completed treatment before 15 years. There are no other comorbidities. Now complaints of localized abdominal swelling, easy fatigability, loss of appetite, and loss of weight for past 2 months. So I'd like to examine biliary system.
No. Give a provisional diagnosis. Yes,
Provisional,
go ahead with the provisional diagnosis.
Since there was a previous history of tuberculosis, first I'd like to rule out.
First of all, there is a localized left hypochondrial swelling. That's all. So you give a differential diagnosis for the possibilities of a left hypochondrial swelling.
Okay.
What is the swelling pathologically, we'll see later. Okay. First, you talk about what could be the probabilities of a left hypochondrial swelling.
That there could be a splenomegaly or a renal mass, or there a malignancy in a splenic flexure of colon, or a tail of pancreas malignancy, or
tail of pancreas malignancy will produce such a huge mass. Okay, then
malignancy of stomach, one possibility is there.
Yes, even there can be retroperitoneal mass on the presenting as a left hypochondrial mass. Yes, okay, that's all. At this point of time, that's all you must say. There is a left-sided mass, that's all, left abdominal mass. We are not bothered about this differential diagnosis. So what could be the mass on the left hypochondrium is what we have to discuss. Yes, now proceed. Dr. Bharati Raja, anything more?
Yes, ma'am.
To be added?
No, nothing, ma'am. I will ask later, ma'am.
Okay.
General examination. Patient was conscious, well-oriented, cooperative, moderately built, and poorly nourished, afebrile, pallor.
What were the parameters of nourishment that you have seen in this patient? Because poorly nourished is a general statement. So what are the parameters or criteria to speak about nourishment. And why do you say he was poorly nourished in this case?
The skin fold thickness is reduced, ma'am. And there is a
Have you examined his weight, body weight?
Yes, ma'am.
Mm.
It was around 58 kgs.
Any idea about the previous weight?
He told there is around 10 kgs of weight loss, but he don't know exactly when it started. He started to reduce weight, but approximately.
Okay, other parameters to assess nourishment. What are the ABCD parameters of nourishment? So what have you done as far as anthropometric assessment? B, biochemical assessment, C, clinical assessment, and D is dietary assessment. These are the 4 parameters of nourishment. So among them, what are all the criteria to say that he's poorly nourished?
Anthropometry BMI, you can see.
What have you done here?
He has a BMI of 21.
But you must have mentioned all that. It's very significant when you're talking of nourishment. Yes. Then? Anything more?
Space.
Have you looked into his eyes? Have you looked into his oral
no
cavity?
Spots. Oral cavity is normal, man. There is no bite out spots or any signs of abnormal nourishment.
Normal nourishment. So when you are committing that there is a poor nourishment, you must give us a picture of what are all the criteria you have used. As I told you, you have to use this ABCD criteria. Yes, continue.
Pallor present, no icterus, grade 2 clubbing present, no generalized lymphadenopathy, bilateral pitting pedal edema present. There is no markers of liver cell failure. There is no markers of TB or HIV. There is no markers of malignancy. Vital signs, pulse rate 82 per minute, normal rhythm and volume, no specific character, no radiofemoral or radioradial delay, felt equally in all palpable peripheral vessels. BP 170 seen in both upper limbs in sitting position. Respiratory rate 18 per minute, it's regular, abdominal thoracic type. No accessory usage of accessory muscles. Temperature normal 98.4, JVP not rising. Systemic examination.
Specifically in a patient who has this abdominal complaint, left hypochondrial swelling, where you expect a splenomegaly, I think 2 more things which you should specifically mention as far as general examination is concerned is, one is oral cavity. For what? And second thing is sternal tenderness. You have not mentioned about that. It's a very significant finding as far as clinical examination is concerned. Those are things that are left out here.
Okay.
What do you expect to see in the oral cavity, or may be there, may not be there? A case of massive splenomegaly. That's what is expected from your title. And why am I particular about this?
Oral candidiasis and tuberculosis.
Candidiasis of tuberculosis. Then, why do I tell you about a sternal tenderness? What does it signify?
CML, there will be sternal tenderness.
Is it exclusive for CML?
No, there is an extra medullary hematopoiesis.
So I think that should have been done. You should have mentioned that. Yes, continue.
Systemic examination, abdomen inspection, skin over the abdomen was normal. Asymmetrical localized distension seen in the left hypochondrium, lumbar and umbilical areas, which moves with the respiration. Umbilicus in midline, inverted, no nodules seen. Decreased movements on respiration over left upper quadrant. No visible pulsations, peristalsis, scars or sinuses. No divarication of recti, dilated veins, or no supraclavicular fullness seen. External genitalia normal, hernial orifices free. Palpation, No
Have you
warmth.
examined the renal angles? Why there is no mention of renal angles? That's also a part. See, you're talking of a left hypochondrial swelling. It can very well be a huge hydronephrosis left kidney. We do not know still. There can be a fullness in the left renal angle. That's again a very, very important aspect of abdominal examination. Again, this is missed. How can you miss out on all those things? It's incomplete.
Palpation, no warmth, no tenderness. Lower border of the liver not palpable. Spleen palpable from 2
Now, why do you say like that? Lower border of the liver not palpable. Is it necessary to say that way? You say liver is palpable, not palpable.
Or not palpable.
Okay. Liver is not palpable.
Because it appears that you should get the lower border of the liver on every examination. It is not so. Liver not palpable. That's all.
Liver not palpable. Spleen palpable from 2 centimeter below umbilicus and 18 centimeter from the left costal margin in the mid-clavicular line. Splenic notch felt on the inframedial border, which is firm in consistency. Moves with the respiration, not bimanually palpable and non-palatable.
Now you are specifically telling that spleen is palpable. You expect the spleen to be ballotable and go to the previous slide. Ballotable and bimanually palpable. Why have you mentioned them? When you are so specific that it is spleen. So why do you say it is a spleen in the first place?
Because it moves with the respiration. I could see palpate this splenic notch.
Then
what about the edges?
Margin, surface, consistency.
It's almost sharp edges only.
Sharp edges. Then, of course, you have mentioned firm in consistency. What about the surface? No, still the first question is unanswered. Yes. Why do you say that it is the spleen? Because you have not examined the renal angles also. Why do you say that this is the spleen? Of course, it moves with respiration. Then, there's one very significant criteria. Are you able to insinuate your fingers between that mass and the left costal margin?
No, ma'am.
Yes, you have to mention that.
Okay. Upper border could not be.
Name structures which are bimanually palpable and ballotable.
Kidneys, ma'am. Kidneys are by.
Yes, continue. If you do not know, please go find out. Then next.
Zipisternum to umbilicus distance is 23 centimeter. Pubic symphysis to umbilicus 11 centimeter. And the upper abdomen to lower abdomen ratio is 2, which is increased. Left anterior superior iliac spine to umbilicus distance is 9 centimeter, and right anterior superior iliac spine to umbilicus distance is 18 centimeter. Spino-umbilical distance is almost equal bilaterally. No palpable inguinal or para-aortic, mesenteric or supraclavicular lymph nodes. External genitalia and scrotum is normal. Percussion.
Deepak, how do you differentiate splenic mass or kidney by palpation methods? How do you differentiate whether it's a kidney or a spleen?
So spleen, the upper border of the spleen could not be palpated, and it moves with the respiration. Whereas in kidneys, it's bimanually palpable and ballatable, sir. And
then usually so edges will be sharp in spleen and round in
rounded in.
I should mention about notch also. Okay. There is no notch for kidney actually, and if it is kidney, the splenomegaly is moderate to it causes the midline. but the kidney usually will not crosses the midline and moves with the respiration, as you said. Okay. Carry on. Continue.
Percussion. Dullness felt at right fifth intercostal space at mid-clavicular line, measuring around 13.5 centimeter. Dullness felt from...
No, you just simply say the liver span is 13.5 centimeters. That's all. See, it is appearing as if you are having some dullness for an unknown reason, right? Say, yes, we anticipate a liver dullness. So you say that the total liver span is 13.5 centimeters. In other words, you're trying to say that there is no shrinkage in the size of the liver. Yes, continue.
On the left side, dullness felt from fifth rib in the posterior axillary line, which is extending still umbilicus, perpendicular in mid-anterior costal margin, measuring about 24 centimeter using Nixon's method. Dullness felt in the left 8th, 9th intercostal space in the anterior axillary line on deep inspiration by using Kessel's method. And trough semilunar space is dull on percussion. There is no shifting dullness or a puddle sign is seen. Colonic band of resonance is felt on right side and it's absent on left side.
Now, why should there be a colonic band of resonance? What do you mean by colonic band of resonance? When will you have that resonance?
When there is splenomegaly, colonic band of resonance is absent.
No, that is not the explanation. I do agree. Yes, but what is your understanding of that statement, of that phrase, colonic band of resonance?
Usually, if the spleen is enlarged, it becomes more anterior.
I'm not talking of the spleen at all. My question is very straight. What is colonic band of resonance?
It's due to colon. If there is a renal enlargement, we could feel the colonic band of resonance.
In other words, when there is an organ, when there is a mass, and when you find that there is a space between the costal margin and that mass, in the intervening space, you have a band of resonance. And this is the colonic band of resonance. So why do you talk of a colonic band of resonance that is felt or not? Heard on the right side? Obviously, there should be resonance because all along you're going to have intestines underneath. So you must understand what you're telling. It is a band of resonance. So that you need not unnecessarily put yourself in trouble by giving this kind of statements. Colonic band of resonance is felt on the, and it's not felt, it is percussed on the right side and absent on the left side. So I think all these are to be avoided.
Okay.
And describe what is Cassell's point and what is the usefulness of Cassell's method and what is its significance in this particular case. First question is, what is Cassell's point? Yes, you have percussed. So what is Cassell's point?
Resonance.
And how useful is this Cassell's method when you have, yes, we all know, everybody knows by now that it's a massive spleen. So how significant is the Cassell's method, applying Cassell's method of percussion in this patient? Okay, what is the normal way by which you do a Cassell's percussion and what is its significance? That just answer that question alone.
By percussion, we can feel the resonance over the left 8th and 9th intercostal space in the anterior axillary line. There is a dullness is felt, we can...
No. Normally, I'm asking for a normal individual.
Normally, there is...
What is the next step you do and what is the next thing that happens when you continue to percuss over the 8th and 9th intercostal spaces in the anterior axillary line?
Okay. Resonance is felt over the 8th and 9th intercostal space normally. No?
Yes. Yes. Yes.
And there is...
I'm asking, I'm telling in a normal individual. I'm not talking of a person with splenomegaly. So what should happen? So what should happen if you ask the individual to take a deep inspiration? What should happen to the 8th and 9th intercostal spaces? Percussion mode.
It's resonant in normal individual, in full inspiration also.
Yes. So normally itself it's resonant. By deep inspiration also it should be resonant. Yes. Cassell's point is that point that is in the 9th intercostal space in the anterior axillary line. That's all. Nothing more than that. Yes, continue.
Auscultation, bowel sounds present. No renal artery bruit or aortic bruit or hepatic bruit. No splenic rub or venous hums. Other system examination are normal. CVS S1, S2, no murmur. RS, bilateral normal vesicular breath sounds, here and all lung fields. CNS, bilateral people equally reacting to light and moves all four limbs. Fundus examination was normal. Diagnosis, massive splenomegaly with Hackett's grade 4 with anemia for evaluation.
Yes, continue.
My probable DD, first leukemias and lymphomas. Massive splenomegaly usually seen in chronic myeloid leukemia, chronic lymphocytic leukemia, hairy cell leukemia, the lymphomas, Hodgkin's lymphomas, non-Hodgkin's lymphomas, then myelofibrosis. Since the patient is a previous history of TB, that could be possibility.
No, we are not asking the reason. Just enumerate and then you can say why it should be or why it should not be. Yes.
Okay. There's a possibility of disseminated TB since he has old.
No, that later. Continue. Kala Azar.
Kala Azar and malaria.
Is it just malaria?
Chronic malaria.
Yes.
Extrahepatic portal vein obstruction or splenic vein thrombosis, one possibility is there. Then autoimmune hemolytic anemia, thalassemia, or any immune-related problems. I have hereditary spherocytosis and sickle cell anemia, which may occur a little earlier than the stage.
No, you first enumerate sarcoidosis, then
sarcoidosis, then rheumatoid arthritis, SLD.
So now you have a big list of differential diagnosis. You tell why it can be CML, why it cannot be. Similarly, you tell for the other things.
Age of the patient above 60 years, no? And there is a massive splenomegaly. Only few causes massive splenomegaly. Then there is no recurrent fever.
No, don't tell about what is not there. Now you are telling why it is CML. That's all, isn't it? You are trying to say
anemia with massive splenomegaly is there. And the age of the patient, based on the age of the patient.
So you want to say that it is possibly CML.
Then second possibility is tropical diseases.
You mentioned about CLL, hairy cell leukemia, lymphomas, myelofibrosis. I would say it is not myelofibrosis. Why do I say so?
Myelofibrosis, mostly pancytopenia picture will be there.
Okay, still we have not gone to that level of proceeding with the diagnosis. The spleen is hard. Here it is a firm spleen. So that's one thing. And what is that distinguishing characteristic in a peripheral smear in a myelofibrosis? Because we have still not come to that. What is that finding in a peripheral smear in a patient with myelofibrosis? Clinically, it's a hard spleen. Have you heard of teardrop cells?
Yes, ma'am.
Why do you think it is not a lymphoma?
There is no generalized lymphadenopathy.
Anything more? Fevers, night sweats.
There is no night sweats, B symptoms.
Why can't it be disseminated tuberculosis?
There is no evening rise of temperature or night sweats.
Not necessary. He has had a past history of tuberculosis. Still, it can be. We have seen patients of splenic tuberculosis. You want to think of Kala Azar here?
No, ma'am.
Why?
Actually, it's endemic to Eastern India as on West Bengal.
Then,
There is no recurrent fevers.
then splenic enlargement is usually faster. It is more rapid.
Okay.
So it will not be the slow 2-month period. Why can't it be chronic malaria? Still, it is possible.
Possible.
Yes, ma'am. Again, there is no recurrent fever.
No, there is nothing like that. You must go read. Chronic malaria. What are the other names for chronic malaria?
Other.
What is another name? There are many names. Give me some other terminologies for chronic malaria. Have you heard of tropical splenomegaly syndrome?
Yes, ma'am.
Tell me one very important criteria to say chronic malaria. You need not have recurrent fevers for a chronic malaria. Patient need not have had clinical malaria at all at any point of time. So this is very important from the history point of view. You must find out if the patient is coming from an area endemic to malaria. That's one of the most important criteria to say tropical splenomegaly syndrome. Yes, then yes. Why can't it be an extrahepatic portal venous obstruction?
There
It's
is no
still possible.
hepatomegaly.
Not necessary. That's one of the most
Ascites.
important. See the why there will be no hepatomegaly? I say there is no hepatomegaly. Why?
So it's in the extrahepatic only, ma'am, but there is no ascites.
We are not talking of ascites or anything. My question is why? Still, I think still you can consider, because this is also one of the differential diagnoses for a massive spleen. Yes, it can still be. Maybe the patient is having a thrombotic tendency. There can be a splenic vein thrombosis, a portal venous obstruction, a thrombosis. It can produce a massive spleen. There's no doubt about it. But why do you say that the patient is not having an extrahepatic portal venous obstruction? I say it is a portal hypertension because of EHPVO or splenic vein thrombosis. What are your points to say no?
There is no ascites.
Not necessary. Extrahepatic portal venous obstruction is not associated with ascites. The patient will not have ascites. Any other reason to say that it is not so?
Location.
What is the fundament? Yes.
Location.
Yes. Yes. History wise. History wise, you need one history. What happens when there's a portal venous obstruction or splenic vein thrombosis? Why is the spleen enlarged? There is a portal hypertension. So what can happen? What can happen? Can the patient have hematemesis? So that will be one important history that you have to, that of course it is not here. So that history has to be elicited, and essentially the liver is normal. You can't expect ascites in this patient. Okay, then autoimmune hemolytic anemia. I say it is not. Why?
Due to the age of the patient will be in,
the patient can develop autoimmune hemolytic anemia due to any reason. He could have had a bacterial sepsis. He could have had a viral infection. You can have autoimmune hemolytic anemia at any point of time. The spleen will never be so large. It is usually a small spleen. Yes. The other causes.
Thalassemia, there is a history of previous blood transfusion or and presentation also late presentation.
Can it be sarcoidosis?
Sarcoidosis, other features of sarcoidosis is not present. Lymphadenopathy or parotid swelling, scleritis, choroiditis.
So from this list, can you further reduce the possibility of the differential diagnosis from this entire list? What are the things that we can still consider?
Malignancy, I could say.
No, be specific, because you have already mentioned. Be specific.
CML,
Yes.
CLL.
CLL occurs at a much later age, and spleen is not so huge as in the case of a CML. The huge spleen, this huge spleen usually does not happen. And as mentioned, there will be lymphadenopathy. So CML from that entire list. Then maybe a tuberculosis because he has a past history. Still maybe a chronic malaria where we have to know the endemicity. Still possible there can be a portal hypertension, extrahepatic portal hypertension. Maybe there is a thrombosis, we don't know. Though there is no history of hematemesis. I think these are the most possible. Would you like to consider anything more from this list? Bharti
Other weekend
Yeah. Oh, I'm asking any other disease, ma'am, like splenic hemangiomas, that is massive hemangiomas, maybe splenic hemangiomas, maybe chance of giving the massive splenomegaly, ma'am. Diffuse splenic hemangioma disease, is there any chance of Gaucher's disease for this patient, Deepak?
No, sir. It will be early adolescent or child.
Okay. Myelodysplasia?
Myelodysplasia possibility is there, sir. Again, it's a moderate splenomegaly, moderate to severe, sometimes massive.
Is this massive, no? This patient is massive or moderate?
This patient is massive splenomegaly.
Massive splenomegaly. Is there any chance of amyloidosis patient getting massive splenomegaly?
Yes, sir. Amyloidosis, moderate splenomegaly, sir, mostly.
Okay. Okay, ma'am. Carry on. We'll
Continue.
continue.
Investigations, CBC, total count was 107,000. Hemoglobin on presentation was 3.4. Platelet also decreased 88,000. They raised the MCV. RFT and LFT normal. Urine PCR was normal. ESR raised and LDH was raised. Urine routine was normal. Serum uric acid raised. Sputum AFB was negative. ICTC non-reactive. A peripheral smear report, which is a presence of blast cells and increased myeloid to erythroid ratio, and presence of myelocytes, metamyelocytes, the immature myeloid and erythroid precursors. Chest X-ray was normal. Echo was done. There was adequate L function. USG abdomen with pelvis. There was massive splenomegaly. And bone marrow biopsy, which also showed the features of CML with the accelerated phase.
Yes.
Treatment was given only supportive treatment. After getting bone marrow, the patient was sent to medical oncology. It was blood transfusion and treatment was based on improving the hemoglobin levels. After bone marrow biopsy,
what is the role of vitamin B12 here?
Since MCV was raised,
so you mean to say that every case that there is a rise in MCVs because of B12 deficiency. What are the reasons where you can have? See, it is not that any rise in MCV is equal to vitamin B12 deficiency. Never, it is not so. In this patient, what do you think is the cause for a rise in MCV? See, there's a massive turnover of cells. So whenever it is like that, the younger cells will be there in the circulation. And that will also raise the MCV. So it is not always about vitamin B12. Of course, it's a water-soluble vitamin. Maybe you're not harming the patient. But then this is not the specification of the treatment. Everybody should not be pushed into B12 and folic acid just because of an MCV. Yes. What is the role of tablet furosemide here? Why do you want to dehydrate the patient by giving 40 milligrams of furosemide every day?
They had anemia with the pedal edema. So we thought of due to anemia, there was failure. Edema.
Is there any evidence? So anemia with pedal edema means what? It's cardiac failure. What are the other things you have assessed as far as the cardiac system is concerned to consider the possibility of a failure? Everything
no
from
rise in
post-graduation level needs an explanation.
there is no rise in
No,
JVP.
I'm not asking about what is not there. What are the cardiovascular findings you expect in a patient with anemia?
Hemic murmur will be there.
Yes, describe the murmur.
It's felt over the left sternum, which is not radiating to axillum, unlike mitral.
No, we are not talking of radiation at all. Where is it first present? Along the left sternal border. Yes, describe the murmur. Is it an organic murmur? It's a functional murmur. Timing of the murmur.
It's a functional murmur.
Yes. Yes. Then, is it systolic? Is it diastolic?
It's a systolic.
Any other murmur can be heard in a patient with a severe anemia. What was the hemoglobin in this case?
Initially 3.4.
Just get back to that. How much was the hemoglobin?
3.4.
3.4. Yes. Yes. I would say that there could be a finding in the neck. What is it?
Lymph node enlargement.
No. I'm talking of murmur. You spoke of venous hum.
Yes.
Can you hear anything like that in a patient with anemia? If so, where? Where?
No.
I've given you all
Over
clues.
Over the carotid.
Over the carotid. Okay, get back. The next slide. Yes. Describe about tablet imatinib. No, we'll come to thank you later. Go to tablet imatinib.
Imatinib is a tyrosine kinase inhibitor. Just given 4 milligram OD for 3 months. After quantification.
You have written something after ABL BCR quantification. What was done? What was the report? What happened to it? What do you expect? And what does it signify? ABL BCR quantification. What does it signify? What was the report in this case?
Percentage of ABL BCR
What was it here? What was it? You must have mentioned that.
Actually, it's done in oncology.
Yes, you have to follow. You are presenting this case. You have to follow.
Okay.
And what is the relevance of this imatinib administration? With reference to ABL BCR quantification.
After 3 months, we have to repeat with the ABL BCR quantification, and we have to look for remission. In 3
what is the duration of therapy?
Months. Usually, it's given based on remission only. 3, 6, and 12 months. Up to 12 months, there is improvement. We can continue with the imatinib. If there is no improvement, we have to switch to. We have to see other mutation like T31 mutation like that, and switch over to second or third generation tyrosine kinase inhibitors.
Name some of the newer tyrosine kinase inhibitors.
Dasatinib, nilotinib, bosutinib, and ponatinib. Yes. Ponatinib is a third generation.
How do you prognosticate in this patient? What are the criteria to say? The patient's attenders come and ask you, how long should I continue? What will be the course? How do you prognosticate?
There are 2 prognostics scores, so-called prognostic score and Hadford's prognostic score. The so-called prognostic score is based on platelets, spleen size, and age. BCR quantification is done on every 3 months, from 3, 6, and 12 months.
Yes.
And if there is a remission, can continue with the imatinib.
Yes. What is blast crisis? Do you
Blast
expect the
crisis.
patient can go for a blast crisis? If so, what? Why? Why should the patient go for a blast crisis?
When there's blast percentage greater than 20, it's blast crisis. Man. When it's between 10 to 19, it's accelerated phase, and less than 10, it's chronic phase.
Yes. So what do you do if it is a blast crisis?
Again, we have to give only chemotherapy.
It's very non-specific. Tell me more specifically. Yes. Varadarajan?
Yes, ma'am.
Just continue.
Any other treatment choices other than tyrosine kinase inhibitors for myeloproliferative diseases?
So only splenectomy is secondary to this.
Any other drugs which may be available? Is there any use of interferons in this case?
Yes, sir. Interferon alpha can be given, I think so.
Which interferon? 2A, 2B?
Sir?
Which interferon?
Interferon
Alpha.
alpha.
Interferon
Can
alpha.
Interferon alpha can be given.
Is it? It can be. It can be given for high risk cases or low risk cases?
I think for high risk cases.
So, what is the use of anti-metabolites in this case? Like hydroxyurea.
Okay.
Whether it is useful or not?
Platelets due to decreased thrombocytopenia we can use.
Yes, have you followed up on the patient? Has the patient come back to you?
Patient started on imatinib and sent home. There is 2 months, or after 3 months, the patient will come.
So here you have a patient with massive splenomegaly with straightforward. So the only thing that you needed was an ultrasound abdomen to assess the splenic size and a peripheral smear and a bone marrow assessment that, of course, clinches the diagnosis. And the patient is on imatinib 400 milligrams OD and on follow-up. Okay. So anything more to add, Dr. Saravanan? Saravanan?
Hello.
You can hear me. So anything more, Saravanan, as far as this case is concerned? You would like to add any more questions?
Not going to add anything. Already covered, madam. Almost covered. I've been listening to you. Please go ahead, madam. Please go ahead. Next case.
Okay. Shall we go to the next case then?
Yeah. Now, Dhanlakshmi okay. Join, madam.
I do not know. She told she'll be here by 9:30.
She's not joined, madam. Is this case of Dhanlakshmi?
I think.
Please go ahead, madam. Please go ahead. I'll continue with the discussion. Sorry, joining.
I'll talk to Dr. Dhanlakshmi.
Hello. Thank you.
Yes. Thank you, Deepak. Thank you. Thank you.
Thank you, Digam.
Sir.
Thank you. Thank you. Nice.
Saravanan, I think Dhanlakshmi madam is joined.
Dhanlakshmi joined, madam. I think
She's joined.
no, she's not joined. Sounds like she's not joined.
But she told I'm joining.
There's a name by name. SSK is there. I don't know. She's SSK. Dhanlakshmi is there or not? Rishi, start presenting. Share your slides.
I'm going to share my slides, sir. Just a minute.
Yeah. Dr. Dhanlakshmi, have you joined?
Hello.
Yeah, Dr. Dhanlakshmi, good evening. Dr.
Yes.
Saravanan here.
Yes. Yes, can you see me, sir?
Yeah. Good
Okay.
evening, Dhanlakshmi.
Good evening,
Yeah.
madam.
Shall we start, Dhanlakshmi?
Yes, madam, you can start.
Saravanan, we'll go ahead.
Yes, please, madam. Please, madam.
Okay.
Please.
Okay. Rishi, start.
Yes, ma'am. I'll start share my screen.
Yes.
Ma'am, just a
Share your
minute, ma'am. I'm
slides.
just moving this.
Okay.
Dr. Rishi, is there any problem, technical problem for you?
Yes, sir. My screen share is not working, sir. That's why I'm just trying to grant access, sir.
Joining through laptop or mobile?
Through laptop, sir.
Okay. You have the green icon is coming for screen sharing.
Yes, sir. I'm just it's asking permission to grant access, so that's why I'm accessing the settings.
Your laptop is asking for permission from the admin, or your laptop is requiring a separate permission.
Yes, sir. That's why.
Okay.
I think it's coming, sir.
Yeah, correct.
Make it full screen.
Yes, sir. Sorry for the delay, ma'am. Sorry for the delay.
No problem. Go ahead. Just go to the full screen.
Yes, ma'am. I will just display the full screen. Well, very good evening to respected professors and assistant professors and postgraduates who are present today. I'm here to present a topic on the interesting effect of anemia. The case, a 70-year-old female patient who's a native of Portugal, who's a known diabetic and hypertensive, was referred from Metropolitan GH as a case of thrombocytosis for evaluation. The chief complaints of the patient.
Go to the slide.
Slideshow. Make it slideshow.
Slideshow.
On the right lower icon.
Yes, ma'am. I put it in slideshow only, ma'am, right now.
You need to have that. Yeah.
Full screen, Marley.
Ma'am, now, ma'am.
You can click on that slideshow. Have you clicked on it?
Yes, ma'am. Yes, ma'am. Now I personally put it in slideshow only.
Screen right end, you will have that, no?
For me,
See
it is coming in.
below the slide, can you see one indication? The and then next to that screen, so I mean a slide sorter. The fourth after that comment, no, you have one.
Yes, ma'am, that.
So
No,
the
no,
icon, it doesn't have the icon for that.
full screen.
Yeah, I'm just looking at.
Ma'am, right now, ma'am.
Usually it goes right on the screen உடைய கீழே டிஸ்ப்ளேல இருக்கும் அந்த ஸ்லைட் சார்ட்டர் மேடம் சொன்ன மாதிரி.
Next to that comment, there is one thing, but actually that exact symbol is not
No,
there.
that is not for that's not for that. Just trying to look at the top one. This is having a different way of looking at this.
Just a minute, ma'am.
Presentation view on the top. Can you click
Second
on
one.
that?
Second one, third one.
Third one.
Presentation view.
Yes.
I'm not getting that icon.
No, not the
top one. Top
correct,
we go
from current slide after that. See next to that. Yes.
Okay. Thank you.
Click on it.
Ma'am, now it's visible in full view, ma'am. Right.
It doesn't matter. You go ahead then.
Okay, you can just
go ahead.
The patient was apparently normal before 3 months, after which she developed a history of easy fatigability for 3 months and history of vomiting of 2 episodes in 3 days, which was non-bilious, non-projectile, and mixed with food particles. The patient had nil other significant history like fever, diarrhea.
Go ahead. Slide நீங்க போட மாட்டேங்கிறீங்க.
Move to the next
slide. Go to the next slide.
Is it visible now, ma'am? The patient had nil other significant history like fever, cough, abdominal pain, diarrhea, bleeding manifestations, and loss of weight and loss of appetite. Regarding the past history of the patient is a known diabetic who was on for the past 10 years on tablet metformin 500 mg PD, and also known hypertensive for past 10 years on regular treatment of tablet amlodipine 5 mg OD and tablet enalapril 2.5 mg PD. She had no other significant past history like coronary artery disease, cerebrovascular accident, or any other significant comorbidities. Regarding personal history of the patient is a mixed diet. Used to take non-vegetarian diet weekly once or twice occasionally, and she had normal bowel and bladder habits, and she did not have any history of altered sleep pattern. Regarding menstrual history, patient attained menopause around 53 years of age, and she had a history of irregular cycle before attaining menopause, but she did not take any treatments for that, and did not have any records for the same. And patient did not have any previous history of transfusions of blood products. On examination, regarding general examination, the patient was conscious, oriented, thin-built, and she was afebrile.
Consolidate. Rishi,
yes,
stop at that level. Don't be in such a hurry.
Okay.
About the history from your slide, highlight the important aspects well. We are just running through all these things, and now you summarize whatever you have spoken and give a possible history, give a possible diagnosis or provisional diagnosis, or at least say what you're going to do further. Of course, it's an interesting case of anemia thrombocytosis. It's different, but now it's a presentation as a PG presentation. Summarize.
As the referral itself was the patient was referred for thrombocytosis since the platelet was around more than 9 lakhs. And the chief complaint of the patient was easy fatigability, which was present for more than around 3 months, which was a chronic complaint. And her acute complaint was vomiting, which was around 3 episodes in the past 2 days. But she did not have any other significant history. Regarding her past history, she was a diabetic and hypertensive on regular treatment of drugs metformin and enalapril. So probably she had we need to evaluate the cause of thrombocytosis in this patient, whether it is a primary or a reactive
thrombocytosis coming to you with easy fatigability.
Yes, ma'am.
So what are all the things you thought of in the first place? Thrombocytosis is the reference. Easy fatigability only complaint from whatever. Did you ask for any paresthesias? You asked for so much of no history of. Have you asked for paresthesias?
No, ma'am.
She's a diabetic. She's a diabetic, 10 years, metformin. And have you asked for any history of paresthesias? Because it's obvious that there can be a peripheral neuropathy. Have you asked for all that? Get back to all that no history.
I did not mention your ma'am, but she did not have any history of pain of extremity.
That's very important that you have to mention that. Very, very important. You're dealing with a long-term diabetic and you're dealing with a patient.
Sorry. And she did not have any bleeding manifestations, which may result in anemia, causing thrombocytosis. And she did not have any loss of appetite and weight to suggest any malignancies. And on her past history, she was taking metformin for past 10 years and amlodipine and enalapril for past 10 years. And she did not have any history of previous transfusions, but she had a history of regular cycles before attaining menopause. The patient could not give a proper history, but she said she had increased flow on and off during her menstrual period. Probably the patient was anemic in a previous history. On an examination, the patient was conscious oriented and afebrile, and she was pallor, and she was not icteric. There was no cyanosis or clubbing, and she was not dyspneic or tachypneic, and there was no period edema and any generalized lymphadenopathy. And regarding the vitals, blood pressure was 130/80 mm of mercury, and the pulse rate was 78 per minute, and saturation was 98% under room air. And the random blood sugar was 178 milligram per which was had a controlled diabetic management. And fasting blood sugar was 151 milligram per deciliter, and postprandial blood sugar was 202 milligram per deciliter.
Can you move to the slide? Next slide. Oh.
Yes. And regarding the systemic examination of the patient, the cardiovascular system examination was normal. Both the S1, S2 sounds were heard, and no murmurs were present. Regarding the respiratory system examination, bilateral laryngeal were present, and normal vesicular breath sounds were heard on both sides. And regarding a periabdominal examination, bowel sounds were heard, and there was no organomegaly or any distension. And regarding the central nervous system examination, it was normal except for knee jerk was diminished and ankle jerk was bilateral ankle jerk reflex were absent. Other than that, other cranial nerve, motor nerve examination were normal. And since regarding the sensory system examination, she had impaired bilateral joint portion and vibration sense in both lower limbs. And the cerebellar system examination was normal, and there was no neck stiffness and no signs of meningeal irritation. Regarding investigations, a complete PET count. The total count was 8,800 cells per microliter, and hemoglobin was 8.1, and mean corpuscular volume was 111.2 femtoliter, and the platelet was around 962,000 per microliter. And renal function test and liver function test were normal, and a urine routine study was also a normal study. And serum LDH was around 160 units per liter, and serum uric acid was 3.8 milligram per deciliter, which was also in a normal range. In order to confirm the platelet count, we did a repeat CBC, and again the platelet count was more than 9 lakhs, which was around 9,47,000. And the lipid profile and ESR were also under a normal range. To summarize, a 70-year-old female patient was a known diabetic and hypertensive on tablets metformin, amlodipine, and enalapril. Was referred as a case of thrombocytosis with chief complaints of fecal particularity and vomiting. And regarding
am I audible, Rishi?
Yes, ma'am.
Okay, no, so there was some problem with my audio and video. Okay, because I had missed quite a significant number of slides. So where are you at this point of time?
Ma'am, I'll repeat the slides, I think.
No, you were summarizing. With that, I lost my connectivity. You were summarizing. I was talking to you about history taking, where you should have definitely asked for history pertaining to peripheral neuropathy, signs of peripheral neuropathy, for the simple reason that she's a long-standing diabetic. You have not asked for history pertaining to tingling, paresthesias. The patient may not know to say, but then I think it's very, very essential having, because every second patient in our wards is patients having long-term diabetes. So I think that should have been asked. And my question at that point of time, before I lost my connection, was you are having a patient who is referred as a thrombocytosis with EC
Yes, ma'am.
fatigability. So my question was EC fatigability, 3 episodes of vomiting, thrombocytosis. What are all the things you will have to come to some kind of a provisional diagnosis. She's come to you with vomiting. She's come to you with fatigability and she's referred as thrombocytosis. What are the things you can think of?
My first differential diagnosis would be anemia, which is probably nutritional cause. And I can also think of malignancies like hematological malignancies. Like since her age group is around 70 years, she might have acute myelodysplastic leukemia. Also, infection could be a cause for thrombocytosis and patients presenting with easy fatigability and vomiting. And drug-induced can be a cause of thrombocytosis with easy fatigability and vomiting.
Can you name some drugs which cause thrombocytosis? Thrombocytopenia, we have any number. Thrombocytosis drugs, because you just mentioned drugs as a cause. So what drugs can cause thrombocytosis? Any of the drugs she's taking will cause thrombocytosis?
No, ma'am. She's taking metformin and amlodipine. None of the drugs can be a cause.
None of these cause.
Yes.
Of course, unlikely, but Vinca alkaloids are supposed to cause thrombocytosis. Okay, then quickly just tell me the clinical. I do not know to what extent you had covered. Yes, go to the next slide. Before that, clinical examination.
Patient was conscious oriented and she was thin built and she was afebrile. And she was significantly pale and not electric, and she had no cyanosis and clubbing, and she was not dyspneic and tachypneic, and she had did not have any pedal edema and did not have any generalized lymphadenopathies. On admission vitals, blood pressure was 130/80 mmol of mercury, pulse rate was 78 per minute, and saturation was 98% under room air, and random blood sugar was 178 milligram per deciliter, and the fasting blood sugar was 151 milligram per deciliter, and postprandial was around 202 milligram per deciliter. Regarding systemic examination, cardiovascular system, both S1, S2 sounds were heard and no murmurs were heard. Respiratory system, bilateral air intake were present and equal on both sides, and normal vesicular bed sounds were heard on lung phase on both sides. And a periabdominal examination, she had no organomegaly and not tender, and bowel sounds were heard. And systemic and central nervous system examination, she had equally reacting 3 mm pupil on both sides, and she had no weakness on all 4 limbs. And her bilateral plantar was flexor, and her ankle jerk were absent on both lower limbs. And other clinical examinations were normal. The only significant finding we could elicit in this patient was that a joint position sense and vibration sense were impaired, bilateral lower limbs, and the ankle jerk was absent, and knee jerk was 1+ in both lower limbs, while other deep tendon reflexes on upper limb were 2+ on both sides. And a cerebral examination was also normal. She did not have a positive rhombus sign and did not have any finger nose test impairment, and tandem walking or dysdialectic kinesthesia was not impaired, and next stiffness and no signs of meningeal irritations.
What about Romberg sign?
Romberg's was negative, ma'am. The patient was able to stand with her eyes closed.
What does it signify?
A cerebral.
No.
And a posterior column.
Have you examined the autonomic nervous system?
She did not have any postural variations.
So what have you examined? What are the minimum things that you can examine in this patient?
Postural variations in blood pressure.
Yes. Have you tried to see?
Yes,
Of course,
ma'am,
I
we
know
did
you
not,
have focused on the anemia or thrombocytosis. I don't deny, but as a clinical examination part, as a postgraduate student, I think when you're talking of the neurological examination, it has to be complete. Yes, postural variation in blood pressure. Anything more?
neurocutaneous markers.
No, I'm talking of autonomic nervous system.
Any sweating, flushings,
Flushing. You list out to me what is the autonomic nervous system examination findings that will be relevant in this patient. Long-standing diabetic. See, because we have so many cases of diabetes, we generally take them for granted. None of these examinations are done. What will you see as far as the simple things, pulse is concerned? What is it that you expect? What is heart rate variability?
Postural variations will be
No,
present.
I'm asking what is heart. I'm not talking of postural variation. You've already mentioned. That's as far as the BP is concerned. I'm talking to you of pulse and heart rate variability. What does it mean? What is heart rate variability? It's one of the very significant aspects of autonomic dysfunction, one among the earliest to occur in a patient with long-standing diabetes. What does it mean? What is sinus arrhythmia?
The patient will have a the
What
impulse
is
will be
sinus
arising from
arrhythmia? It's physiological, pathological. What does it mean?
the impulse arises from a sinusoidal node.
No. Don't go to that. What is sinus arrhythmia? That's all. But this is so fundamental. And if you don't know this, there is no point in talking of autonomic nervous system. So find out what is sinus arrhythmia, what is heart rate variability, what are all the things that change, some earliest changes to happen whenever you have autonomic dysfunction in a long-standing diabetic. And what is Valsalva maneuver? What can be done? And what does it imply as far as autonomic dysfunction evaluation is concerned?
The asking the patient to perform a Valsalva maneuver may cause a change in
to do?
Patient to close the nose and blow through the patient's mouth. And,
you better go to read autonomic nervous system. See, because in this patient, the clinical findings pertain to the neurological system. So when that is the case, your examination has to be thorough. It includes, what about examination of the spine and cranium?
she did not have any kyphosis and scoliosis, ma'am.
And you have to mention all that. See, every aspect of neurological examination is significant because here you have some findings. And that means that you have to make your examination thorough. So the spine and cranium examination has to be mentioned. Very important.
Okay.
Yes.
So
what is your observation from the neurological examination point of view? What is your observation? What has she got?
She has a posterior column involvement and
as evidenced by
impaired joint position and vibration sense in bilateral lower limbs.
What do you mean by bilateral lower limbs? I would like to ask you. That means have you examined for vibration sense and joint position sense in the hip? Is it absent at the level of the hip? What is your meaning of bilateral lower limbs? See, it's so non-specific. Joint position and vibration sense impaired on bilateral lower limbs. What do you mean by that? So you have the hip joints, you have the knee joints, you have the ankle joints, and you have the metatarsophalangeal joints, and you have the interphalangeal joints. Which joints? You have to be specific. You can't give such vague statements. Joint position sense absent bilateral lower limbs. From where?
From the level of knee joint and then also ankle joint.
Knee joint. Name conditions where you have such a gross loss of, that means you have not examined at all. where you have such a gross impairment of joint positions of the major joints. I have not seen in my 3 decades of teaching, I have not seen one patient with joint position. Earlier, we used to talk of tabes. Saravanan, am I right? Tabes dorsalis.
Correct, madam. When you
Ah,
have this patient, this type of joint position sensation, think about tabes dorsalis. Or
exactly.
proximal limb or upper limb, you can also think about joint stability is gone, syringomyelia,
Hmm.
all those stuff can be happening. Otherwise, you don't get, and such a gross defect is unlikely. A patient cannot walk because the knee joint is the main weight bearing joint, where the
Ah,
joint stability has gone. So patient cannot walk, tend to have damages, frequent falls can be there.
yes. The patient has
Sorry,
come to you walking, and you're now
sorry,
telling that the joint position is absent in the knee joints. No, Rishi, I think it's not examined. Can you
while
describe how you? Yes,
Probably, madam, probably is more focused into the anemia part
anemia
and
part.
as
No,
well.
I do agree.
Yeah,
But as a
yeah,
PG teaching class, I
yes,
think all
yes,
this is
yes.
very important.
But
And
Rishi,
can you?
madam trying to highlight to you that the importance of examine the patient holistic nature.
Yes,
yes,
Irrespective of the case, whatever the nature of the problem, you try to spend your time, maximum time with the patient, especially at your postgraduate learning period time. It's the high time for you to sit with the patient, examine it thoroughly. Even though you're very clear in your diagnosis, if the striking spotter might be, doesn't matter. You try to spend. That's why you're going to learn. It's only the material what you got is very good materials, clinical materials. You're going to spend time with the patients. Okay. That's very, very important. That's what madam is trying to highlight you and catch you on this part specifically. And sticking on the same point is the importance is lost of the clinical medicine. That's
yes,
a
yes.
big problem which you are doing. Probably you are you're more biased towards the topic which heading which you given. Interesting
Exactly.
effects of anemia or thrombocytosis, whatever. You got biased. So don't do that hereafter. That's always good.
yes.
Okay. I
Because
got two,
not
three
just
questions for you.
investigations.
No, no, I
Clinical
just have
part
two.
is very important.
Let me ask him
That's
two,
all.
three questions,
Oh,
madam.
sure, sure, sure. Go ahead, sir.
Yeah, yeah. And Rishi,
Yes,
you mentioned about at the end of the history, and
yes, sir.
you mentioned about the possible differentials for anemia, fatigability. For fatigability is anemia, and you also
Yes.
mentioned about with the thrombocytosis, you thought about differentials of acute hematological malignancy. What made you to
Yes.
think the differentials in this order?
Sir, the complaints of is
Sorry, at a postgraduate level, when you're going to offer the differentials, should have a clinical meaning in that. Okay, out of your many points which are going to gather from the history and examination, should have a major points in favor for the first diagnosis, 1 or 2 points less for the second, third, fourth. You cannot go beyond the differentials. So you stuck on to 2, 3, that's acceptable. I mean, my question is about what made you to think the order.
um, a complaint of
Got
a
the point?
female patient of 70 years old with easy fatigability for 3 months. The most common presentation would be an anemia in our country, sir. And
Can't this
since
be hypothyroidism? Why can't this be vitamin D deficiency? That's what once again the same
Exactly.
point is coming here. Don't try to be more biased towards whatever the reference is. Reference is very clearly written to you that saying that please evaluate this patient for thrombocytosis. Okay,
yes, sir.
and but doesn't mean that you're not dealing with the additional problems. That's what once again the point is to be highlighted here, and madam is trying to force on you is the same point. Okay. So you should
Okay,
have a
sir.
clear idea about the differentials you're going to offer, irrespective of the case. Clear idea about the points, the major points for and against. Then try to order the differentials. Don't randomly throw up the differentials without any clinical evidence, both
Mhm.
historically as well as examination wise. Right? Am I clear to you?
Yes, sir. Yes, sir.
Yeah. And how much it is possible to have acute this type of hematological malignancy, especially mentioned about AML, correctly remember, how much is going to be
Yes, sir.
common in this age group?
Um,
Is it having any
more,
bimodal distribution, AML?
no, sir. It's more common above 60 years of age group.
That's what, does it
Um,
have any bimodal distribution? That's what I'm asking, bimodal distribution.
no, sir.
Two extremes of age group.
Um, no, sir.
Because
It's
when you
more
ask about the differentials, straight away thrown up these two differentials only. right? So you can also think about non-hematological, because the question is open. It is not very closed-end question. Understand? So try to have some clear idea about you when you ask the question the examination point of view, even though the reference, all those stuff may not be there in the examination. What I'm trying to highlight here is try to have some differentials for different system involvement.
Exactly.
Okay. The topic for today's discussion is going to be hematology. Dr. Dhanalakshmi, the professor of pathology, is there. But doesn't mean that we should not discuss or you cannot expect the coexisting other problems. Understand?
And she's
Yeah.
also a diabetic. In relation to
Yeah.
her diabetes, with this presentation, what are the other differentials that you can afford to consider? See, it has to be, as Dr. Saravanan pointed out, it has to be a holistic approach. So she's a diabetic, she has thrombocytosis, she has fatigability, she has vomiting. So you have to consider a different set of differential diagnosis for each of these. So giving her underlying diabetes, what are the things that you have considered? She can have a CKD, because she's got vomiting, she's a long-standing diabetic, fatigability can be a part of the renal disease. You can think in that terms also, or maybe she's going for hyperosmolar syndrome, or maybe she's going for a DKA. That is also possible. So don't get yourself narrowed to that possibility of only fixating over thrombocytosis and anemia. This is a pure
Okay.
clinical postgraduate discussion. With that in mind, you have to present.
So two more questions to you, Dr. Rishi. You mentioned about
Yes,
the
sir.
patient was on metformin. We'll just
Yes, sir.
possibly finish off this non-hematological discussion. We'll move on to, because Dr. Dhanalakshmi is waiting for a long time. So the metformin the patient is taking, do you have any idea from the literature support how much grams of metformin to be taken for how long to produce neuropathy or anemia? Start with anemia, then only go for neuropathy. So anemia to produce how much grams of metformin for how long? There's the evidence is available. I'm asking about, do you have any idea about the evidence? Okay, make it fast and easy for you to understand. It's a 3 grams or 2 to 3 grams of your what do you call 2.5 grams, at least 2.5 grams of metformin for 3 to 4 years. Consider it 4 years is enough to produce anemic changes. This is the evidence available in the literature. Go and refer literatures regarding this statement. Number one. Suppose this patient is having metformin-induced anemia. Mild neuropathic symptoms are there because of diabetes and metformin-related. If the symptoms are worsening, in the context of this today's discussion, what you are trying to highlight here is hematological problem. How are you going to explain that worsening of neuropathic symptoms in this patient? The pre-existing metformin diabetes-related neuropathy is getting worsening. How are you going to explain that worsening of neurological symptoms in the context of today's hematological discussion?
Patient developing any paresthesias or
Correct. No, worsening of neurological symptoms. We don't discuss in detail. Question: how are you going to explain with the reference which you received in relation to these neurological symptoms with the pre-existing diabetes, already was on metformin, having neuropathic symptoms, now got worsened. 6 months worsening. How are you going to explain that?
maybe any additional infections or may worsen the
How
symptoms.
come it's common to have infections induced worsening of neurological symptoms? I'm talking about hematological topic which you're trying to highlight today in relation to that and worsening of neurological symptoms. So when you have a patient at the age of
Maybe
60s and
increasing the
70s,
dose of the metformin
no,
may worsen this.
understand. No, understand. The problem
Yes.
of pre-existing diabetes neuropathy, metformin plus diabetes neuropathy, getting worsening with the today's context of your clinical hematological problem that you're trying to highlight, or for which the patient has been referred to you, it sounds to me more of the primary proliferation of thrombocytes producing the neurological symptoms getting worsening. You talked about primary versus secondary, I remember, right?
Yes, sir.
When I told
Yes, sir.
about the 900,000 platelets, you said about can be a primary, it can be secondary to anemia, also mentioned on bird. So it's less likely to be secondary, more likely to be primary. Because the primary myeloproliferative disorders tend to have, especially the polycythemia rubra vera and your platelet related disorders like thrombocytosis, can have infiltration of the neurological system, especially peripheral nervous system, can produce worsening of the symptoms. So they add point to that because I'm talking about when you get a case in the examination, you're trying to explain. Are you going to say that it's a primary versus secondary because you don't have any investigation? When the stem is carrying information about thrombocytosis, 900,000 cells per cubic millimeter, then you can think about possibilities of primary as the main reason for your neurological symptoms getting worsening. Okay. And did you mention about the secondary symptoms, which is usually the patients experience with myeloproliferative disorder?
Sir, like loss of weight.
Yes. Fever
She
can
did not
be
have any.
fever
She did
can
not
be
have
there.
any fever episodes or loss of weight or loss of appetite. So,
What are the skin changes you can get in
yes.
the peripheries? Skin changes in relation to not diabetes, but in relation to the hematological problem which you're trying to highlight today.
Any petechiae bleeding manifestations can be done.
So it's so high count, do you expect bleeding or thrombosis?
Thrombosis. So,
Are you sure? Sometimes leading questions can be misleading you. Leading questions can be misleading, especially for postgraduates. Okay. So when you have a thrombocytosis of this nature, it's a primary proliferative thrombocytosis. You expect more of fragile cells than to be stronger cells as usually. Understand? The chance of bleeding is going to be equally important in compared to your thrombosis. So both are equally important. Okay? Very important. So we're going to ask for bleeding tendency in this patient with the background of referral for thrombocytosis. What are the possibilities you can think about? I'm asking about clinically what are the things you like to look for, examination wise, history wise. Are you expecting deep seated bleeding? Or are you expecting superficial bleeding?
superficial
Or are you
bleeding.
expecting the bleeding only because of thrombocytosis or anything else?
Superficial bleeding by bleeding gums and
No, my question is about are you expecting, be clear and understand and follow my question. Are you expecting superficial bleeding versus deep bleeding? And tell me what are the reasons for it's only because of platelets or anything else?
I'm expecting a superficial bleeding and
Okay, why? Justify why.
more has to do because of the fragile cells and impact function of the platelets.
Hmm. Okay,
And,
why? Why you are not expecting only, we are expecting only platelet disorder, nothing else? So in any myeloproliferative disorder, keep in mind, any myeloproliferative disorder, it's always common to have, especially in relation to this today's topic, which you're discussing thrombocytosis, the chances of bleeding is going to be there because of dysfunctional cells or immature platelets also, number one. Number two, there's a chance of coexisting coagulopathy is very, very common, especially acquired von Willebrand disorder. It's going to be coexisting with the patient. They can also get other factors deficiency also in this patient. So always try to have an idea about deep-seated as well as superficial bleeding. Both can happen. This is applicable for polycythemia rubra vera as well as thrombocytosis. Understand?
yes.
So it's very important because most of the time we always blame the cells, but the chance of coexisting problem is very, very important. You have to evaluate for that and try to address that problem because addressing the coagulopathy is going to be a different way compared to your platelet disease related treatment plan. Understand?
Yes.
Yeah.
Yes.
So this patient is on diabetic medicine, for example, pioglitazone. Glitazone.
Okay, sir.
Do you have any idea about hematological complications secondary to glitazone? Already we discussed about metformin-induced problem. Glitazone-induced hematological problem.
No, sir.
Any idea?
No, sir.
No. So the glitazone has got the tendency to what I call deform the stem cells from converting into matured blood cells into a fat cells. it changes the character of your cells from forming the mature cells of red blood cells or platelets or your white cells. It changes the character of the primary stem cells into a transforming into fat cells. So chances of anemia is going to be more common seen with, especially applicable for red blood cells, more common seen with glitazones. So it's because of the character of its, the mechanism of action that changes the character of the primary stem cells and producing. It's a bone marrow changes which is expected from the glitazone therapy in this diabetic treatment. Okay, it's very important. Just trying to learn some important points because topic is hematology. I request Madam, please go ahead. Dr. Dhanalakshmi also waiting. Please add more inputs
No,
related
now
to
with
this.
investigations, I request Dr. Dhanalakshmi to come in. Dhanalakshmi, please go ahead.
Yes, madam, I'm there.
Continue,
So-
Rishi.
Yes, ma'am. Regarding
Yes,
investigation.
Dhanalakshmi. Wait. Sorry. Dr. Dhanalakshmi would like to ask.
Actually, you have shown the approach to thrombocytosis, one slide. Can you go to that?
Yes, ma'am.
Yes.
This slide, ma'am.
Yes. Apart from what you have mentioned, from the lab side, generally, for you to know, can you expect any other cause for thrombocytosis?
Secondary causes of thrombocytosis.
Apart from what you have mentioned in the approach, all the causes, sometimes there is a spurious thrombocytosis. What is spurious thrombocytosis?
Because of collecting the blood sample, there might be a.
So that is, see, although we don't get such high counts, but you should always remember spurious or pseudothrombocytosis, which can be due to some fragmented red cells or cryoglobulins, which can be counted as platelets by the analyzer, automated analyzer. So giving a falsely high counts. So that is one thing you should always remember from the lab side. Always any unexpected increase or any decrease in the count, we have to always check with the manual count, platelet count. From the lab, you have to verify whether if there is anything wrong from the lab side also. So that also you can mention apart from the secondary causes. And what is the cause of thrombocytosis in this case, as the patient is having iron deficiency anemia?
Yes, ma'am. Reactive to iron deficiency, the patient is having a reactive thrombocytosis.
Yes. So what is the main cause for increase in the platelet count?
Sometimes because of the iron deficiency, the erythroblastic and megakaryocytic progenitor cells are more committed towards the megakaryocytic proliferation. There's not an exact mechanism has not yet been fully studied, ma'am. But few studies suggest that this is the mechanism behind the thrombocytosis and iron deficiency anemia.
So you have to be more clear, like you have to mention that usually erythropoietin is stimulated, like in iron deficiency. And apart from that, even interleukin 6 also has been mentioned as one factor which can stimulate thrombopoietin. So thrombopoietin will be it is not able to control the effect of thrombopoietin. So this thrombopoietin will be more, and it will stimulate the thrombopoiesis, platelet production. Okay, so either it's due to erythropoietin or even interleukin 6 and certain catecholamines have also been implicated as a cause of thrombocytosis.
Okay.
And you have, can you go to that slide, previous slide?
Yes, ma'am.
So what is the most common leukemia which you expect to cause thrombocytosis? Among the leukemia?
Chronic myeloid leukemia.
Yes, chronic myeloid leukemia. So in this case, what is lacking when you want to exclude myeloproliferative disorders in the abdominal exam?
organomegaly, like splenomegaly.
Massive splenomegaly. And you have also mentioned hemolytic anemia as a secondary cause of thrombocytosis.
Yes.
So can you explain what could be the cause?
Sorry, ma'am. How does hemolytic anemia causes
Yeah,
thrombocytosis?
irrespective of the age of this patient, in general, I'm asking. You have mentioned hemolytic anemia as a cause of secondary thrombocytosis.
Okay.
So what could be the cause for that?
Because of enlarged spleen, that the
So usually in hemolytic anemia, you don't get massively enlarged spleen. It can either shrink in size or it could be normal. So, but there is a functional asplenia. That is due to occlusion of, so for example, if you take a sickle cell or some anemia, these cells could occlude the arterioles and cause small infarcts in the spleen. Okay, autoinfarcts, repetitive autoinfarction, causing functional asplenia. That is one explanation for thrombocytosis. So, why do we get thrombocytosis following splenectomy?
because of the absence of spleen, the sequestration of platelets will be defective,
So,
and
the spleen is the main organ, is one of the main organs where the platelet destruction happens. So, because of that, you get this one. So, what mutation will you like to do in case of these myeloproliferative disorders?
JAK2 mutation studies, the THPO mutation studies, and MPL mutation studies.
Okay. Okay,
Any
that
other
you
mutations? Any other
okay.
mutations? Rishi? You're talking about thrombocytosis. Any other mutations will be very much helpful.
The
Do you have
GS10
any idea?
mutations.
Percentage of distribution or positive reports for JAK2, COL, and MPL. CRL also can check for. It's also one of the important investigation mutations can be checked for. Do you have any idea distribution of percentage of this positive mutation studies?
Also.
No. Okay. How much it is common to have anemia-induced thrombocytosis to this level of 900,000?
So usually mild to moderate thrombocytosis is common in iron deficiency anemia, so around 5 lakhs to 8 lakhs. Severe thrombocytosis is very rare presentation in iron deficiency.
Very rare. So it is not ruled out. It is very rare. So you can get 900, even 1,000 also you can get. But it's not a common one. So when you have a number of this much very high, always think about primary then secondary, especially secondary to anemia. It's very important. Okay. Yes. And what is your patient's MPV and PDW?
So
Similar to MCV, mean platelet volume and the platelet distribution width.
the patient's main platelet volume. Yes, sir. Sorry, sir.
How
Is it
much?
important?
That's what is asked. What
Yes,
is
sir.
NPV and platelet distribution bit? What do they suggest?
Mean platelet volume is 7.7 centiliter for this patient, and platelet distribution which is also 9.7, sir.
Okay.
For this patient, the mean platelet volume is around a normal range. If a mean platelet volume is increased more than the normal value, we can consider the possibility of a primary thrombocytosis. And if it is in a normal range or low normal range, we can consider the possibility of a secondary thrombocytosis. So,
Dr. Dhanlakshmi, would you like to add any points regarding this MPV and PDW in relation to thrombocytopenia versus thrombocytosis?
Nothing much, sir. I actually, in case of thrombocytopenia, this immature platelet fraction is helpful, but MPV is one point is already mentioned.
Yeah. So when you
Yes.
have a MPV is more number, means more than 12 femtoliters or 13 or 14. The big size, most probably can think about immune thrombocytopenia. I'm thinking about thrombocytopenia. You can think about big cells, giant platelets are there. You can think about possibilities of immune thrombocytopenia. But in case of thrombocytosis, it has got its own limited values, whereas the PDW also varies, depends on the size of the cell. That's a basic point you should remember when you're dealing with the platelet disorders, especially clinically. When the pathologist is going to give a report, think about and look at the MPV as well as the platelet distribution with as well. Okay? Yeah.
What is that PCP, Rishi? What is that?
Platelet grid, ma'am. How much?
What does it signify? Platelet grid. Okay. What does it signify?
The amount of platelets present in particular that was increased in this patient than
how do you
value.
describe hematocrit? Similarly, you give an explanation for platelet crit. And what is the normal?
Normal is around 0.3 to 0.5%. It was increased in this patient to value of around 0.73%. And
okay, proceed.
The ESR is normal, right? Slightly above normal value. What do you expect?
Female patient anemia 25, I think, is quite normal. With an underlying anemia.
Underlying anemia, thrombocytosis. Do you expect any change in the values of the ESR? The two contrasting numbers.
Should have been increased for this patient, but it was in normal range.
Why do you expect
erythrocyte sedimentation, no?
Yes.
Factors determining erythrocyte sedimentation rate. Usually female it is higher. And what are those factors? We already read in physiology regarding that androgen factor and all those things. I do not know, maybe I'm wrong. But I think it's reasonably okay for this patient, isn't it, Saravana? Maybe Dan Lakshmi should be a better person.
The only point is here, discussion is we have a thrombocytosis very much elevated, but not necessarily any cellular component is going to be more. And it's also going to influence by the other parameters of plasma materials, also going to influence, especially albumin values or globulin values, mainly going to change your ESR values. So in that case, the ESR is expected to be very low with the thrombocytosis, whereas anemia is going to be more. Probably got some amount of neutralization has happened over there and producing near normal, slightly above normal value for this lady. So we have to think about the possible expected, but there are two contrasting pictures there, anemia and thrombocytosis. That is probably nullified the effect on the ESR per se by the individual components. But when you're going to present the examination, when you're going to analyze any complete blood count from the clinician's point of view, especially at the postgraduate level MD, always try to have these parameters, which are your indices you're mentioning here, very important parameters. You try to look at those indices and try to interpret the report. It is not looking at the only number of platelet. It is not only looking at the number of hemoglobin or white cells. Always try to have an idea about these indices are very, very important indices to guide you what investigation next you can proceed with. Rishi, are you there?
Yes, sir. Yes.
Yeah, please follow. Yeah.
Okay.
Thank you.
Since we also plan for invasive procedures like bone marrow study and flow cytometry study for this patient, but the patient was not willing for any invasive or cost-effective, cost-involved investigations. So we started working for the patient to rule out primary, secondary, and inherited causes. Since the mean platelet volume was on a normal range, we ruled out the primary causes, and since the age of the patient is in a later presentation, we ruled out inherited causes, and we worked up for secondary causes of thrombocytosis. The patient did not have any symptoms of fever and other manifestations of any infections like raised total count or raised ESR. So we ruled out the possibility of infection and inflammations. And she did not have any history suggestive of malignancies like any loss of weight, loss of appetite, and on examination also, she did not have any features suggestive of malignancy. So we ruled out the possibility of malignancy, and we did a peripheral study for this patient. She did not have any evidence of hemolysis and serum LDH.
Go to the slide.
Yes.
Where is the slide of that smear?
Yes, the peripheral smear, the manual platelet count was 962,000 for this patient, and the red blood cells were of moderate NSCytosis and poikilocytosis, normocytic normochromic anemia with microcytic hyperchromic anemia and few macrocytes. And our reticulocyte count was 0.8%, which was reduced. And the overall impression of the peripheral smear was dimorphic anemia with thrombocytosis. And there was no evidence of hemolysis in the peripheral smear for this patient. And regarding she not have any evidence of post-splenectomy also on the peripheral smear like oval joint bodies, and she not have any history of surgery or burns.
No, see, all that is over with the history, Rishi. We are now, I think, in the investigations. We have ruled out infection, inflammation, everything. All that is over. Now we are looking into the investigations. What about the serum B12 has been done?
Yes, we did mention that was also more than 13, which was suggestive of iron deficiency anemia. So did a iron profile study and B12 study.
Talk a bit slow, no? We talk a bit slow and be clear. You're just rushing through.
Sorry.
Yes, what is that index?
Menzer index is calculated using mean corpuscular volume and red blood cell count, and it was more than 13, which was indicative of iron deficiency anemia. And so we did an iron profile study for this patient along with between B12 studies or mean corpuscular volume.
Go to the slide. Yes.
And this is the iron profile study of the patient. Her serum ferritin was 22 nanogram per deciliter. The reference range for the study was the normal was more than 80 nanogram per deciliter, and serum iron level was also very less, around 7 microgram per deciliter. And our serum vitamin B12 level was also 120 nanogram per deciliter. The reference range was more than 200 nanogram per deciliter. So with this iron profile study and B12 serum B12 study, we came to a conclusion that the patient had iron deficiency anemia along with B12 deficiency, which was the cause of reactive thrombocytosis for this patient. And hence, we started the patient on iron supplements and B12 supplements in the form of injection of vitamin B12, 1000 microgram IVOD, and single dose, and injection iron sucrose 200 mg and NS IVOD. We also stop the patient from taking metformin, which is also one of the causes of B12 deficiency. And we started on a patient on human insulin injection for a diabetic management. And this was the CBC monitoring of the patient as we started on supplementation, B12 supplementation.
So what is the need for a daily monitoring? Do you think overnight it will change, is it? Overnight, the platelet count will come down. Overnight, the MCV will drop down to normal. What is the need for a daily assessment? The patient is already anemic. Why do you unnecessarily have to bleed her every single day? At least a minimum of a week has to be given. So from 15th to 21st has been a series of investigations, which I personally feel is not right to go for so many investigations. Yes.
Acceptable, madam. It's correct. Because clinically speaking, you don't require a hemoglobin monitoring. The patient is hemodynamically stable. You're not transfused.
Exactly.
You don't expect immediate increase in the hemoglobin part with your iron infusion alone. At least we have to wait for a week or 10 days to see the improvement. Oral iron preparations, 1 month you have to wait for see the improvement.
Yes.
Hemodynamically okay, it's okay. Transfusion is given, you are planning for a surgery, preparing the patient for some other procedures. Your transfusion, you want to check on the numbers, copies and other things. Yes, fair enough to check, but not necessarily on a daily basis. And unless you have the actively bleeding patient, GA bleeding, you're admitted the patient, you're monitoring. Yes, it's fair enough to request for the hemoglobin part. So otherwise, there's no point of doing, especially when you're made your mind that diagnosis that iron deficiency doesn't require so much of frequency of investigations, especially related to hemoglobin. Yeah. But Rishi, this patient is having, for example, coagulation profile is assessed. His PT, APT value is normal, but is actively bleeding. What else you can think about?
Vascular pathologies, any collagen vascular disorders.
And before that. So fair enough to think about that way, but more common than that, still we have not completely ruled out the coagulation factor deficiency. The PT, APT value is normal. The pathologist given the report as normal value. What will you think related to coagulation profile is concerned, still there's a possibility of a deficiency. Which factor deficiency?
So 1 milligram.
Anything else? Usually, what is the value abnormal in case of 1 milligram factor? Clinical textbook wise?
The APTT will be prolonged.
No. What is the factor? Sir is asking very specifically. What is the factor that is deficient?
Other than
Factor
1
8.
milligram.
Factor 8.
No. It is always to be thought about as a factor 13. Okay. So when there is a PT, APTT value is normal. Clinically, when you have a patient suspected coagulopathy, suspecting clotting factor deficiency, you did your primary screening. You're supposed to go for only with the history, suspecting clotting factor deficiency, going for PT, APTT normal. Don't get shocked. Probably you need to go for assessment of your 1 milligram factor assay, followed by your factor 13 also. You talk to a pathologist and try to convince them to go ahead with the separate assessment of the clotting factor assay of factor 13. You may not be surprised to see that it is deficiency can be there. Dr. Dhanlakshmi, your input regarding this?
Sir, I'm not very sure about this. I'm not.
Yeah. So this is the clinical point. I'm just trying to tell the postgraduate also. So when the PT, APTT is normal, always think about factor 13 deficiency. Always think about it. And 1 milligram assay. And usually the clinical textbook wise bleeding time is the ideal one to go for to check for the 1 milligram deficiency. But ideal one is not the bleeding time. It is always to be checked for the assay. We're treating with dealing with the problem of 1 milligram deficiency of 1, 2, 2A, 2B, 3, whatever you're dealing with, that has to be checked perfectly with assay. Because you might be dealing with antibodies also, especially in case of thrombocytosis, erythrocytosis. Very important to have a thought about this. And main important point I would say in this thrombocytosis patient, even though you claim it is because of iron deficiency, as you said, the patient is not willing for bone marrow. I would say it's still limited investigations we've been taken with, right? Are you accepting that or not? Dr. Rishi?
Yes, sir. Because we
The
were.
patient is not willing for, acceptable, not willing for, you cannot proceed with. But still you have to conclude that not a complete investigation, right? It's a must to go for coagulation assay. Number 2 is to go for bone marrow examination also. It's a must. Okay, even though it's suspecting strongly,
Yes.
right? Yes,
Okay, sir.
madam, please.
Continue, Rishi. Next.
And the patient was, after completing 5 days of injection of vitamin B12, she was planned for discharge and advised injection B12 once weekly for next 4 weeks and then once monthly for next 6 months at nearby GH or PHC. And she was also suggested oral supplementation of iron, which was 3 tablets of 200
Why
micrograms
3 tablets of ferrous sulfate? Is it so easy to consume 3 tablets of ferrous sulfate per day, Rishi? How much of ferrous sulfate is being given in our institution? What is the dosage?
200 mg.
What are the
200
dosages
mg.
available?
200 milligrams of ferrous sulfate tablet is available now.
How much does it? How much is the elemental iron per 200 milligram of ferrous sulfate?
60 milligrams. No.
How much?
60 milligrams.
60. Okay, good. What is the need per day for this postmenopausal woman?
1 milligram per day.
No. How much of elemental iron? Okay, 1 milligram
per day.
is it so?
Okay.
Even if you're going to go by your standards and depending upon the bioavailability, why should you give? See, 3 tablets. You should be very, as a proper PG level, all these things you should know. 3 tablets of ferrous sulfate per day on empty stomach. Do you think she will withstand even for a day? So let us be very practical. She is definitely not going to follow your treatment. I think that's something that you have to, we have to take care of all these things. Every step is important. Don't you think so, Dr. Saravanan? 3 tablets of ferrous sulfate.
Very, very difficult to follow. Even
Not
single
possible.
step can produce severe GI disturbance. So
Yes.
making the patient to take 600 milligram of iron preparations and to have only 80 milligram of elemental iron, it's going to be very much non-compliant with the patient.
Yes.
Okay. But do you have any idea the newer preparations available to make the patient more stomach friendly?
And what is the latest up-to-date suggest as far as oral iron consumption is concerned? How to consume, how frequently to consume? What is the latest as per up-to-date regarding oral iron therapy? And as sir has asked you, what are the newer GI-friendly iron supplements?
Ferrous fumarate and
But still it's almost equivalent to your ferrous sulfate. Not so friendly. The two newer preparations, definitely practically speaking, in a real world scenario, with the evidence available, much better stomach or GI friendly than your ferrous sulfate or fumarate. So you have the ferric pyrophosphate preparation. This is more stomach friendly. You may not be requiring your this much of a number of tablets for this. And glycine based preparation is also available in the market, which can be prescribed to the patient instead of going for ferrous sulfate. Can understand from the general hospital is very difficult to prescribe, but as a postgraduate should know about the available materials at present in the clinical setup, right?
Very important.
Very
And
important. Yeah.
also, as per up-to-date, even alternate day therapy is sufficient to be consumed along with citric juices. That is more, that will enhance the bioavailability of iron when you combine with vitamin C. So I
That's very
think
important.
even at least, even if we are going to go on a daily basis, I think it should be something where the patient can comply with your prescription. So I think you must take care of all those things when you, as a postgraduate, is going to advise the patient regarding a long-term management because she's nutritionally deficient. Yes.
Suppose you're adequately treating this patient with iron replacement as a oral therapy to start with. How long would you have to wait for to see the initial response with the oral therapy iron?
sir, around 1 gram of hemoglobin increases in 1 week, sir. So we have to continue the treatment for around 7 to 8 months for a patient.
No, the
So
question
severe
was
anemia.
different. I
No,
think, sir.
perfectly followed and available evidence. You have to wait for at least to start seeing the improvement at least a month's time. Because do you know what is the percentage of absorption for the iron preparations? Why do you want to administer 200 milligram of salt to provide 60 milligram of elemental iron? In that, how much you'd expect the absorption to happen? Any idea, Rishi?
Around 1%.
No, it's a 10 to 20 percentage, not more than that. Meaning that we're going to provide the patient 60 milligram of elemental iron. The absorption might take place maybe 6 to 12 milligram, not
Yes.
more than. How much is going to reach to the site is very different. But what is the absorption is happening? Where is it happening? Iron absorption.
Sir, in duodenum.
Which part of the duodenum? More precise. See, iron therapy can be short notes for your postgraduate examination, part 1, right? And iron metabolism can be short notes for your thought. And similarly, you can get the essay of hemochromatosis. You're supposed to write your iron metabolism. It's a small portion of your hemochromatosis essay. Okay? Yes. Please, madam, please. I think 10:35.
Okay, so tablet glimepiride. So you have dispensed her with the glyciphage, is it? I mean metformin. I don't think it's contraindicated. 500 milligram, according to what you say, is only by twice a day. Okay, so you're advised to review with repeat CBC after 1 week. Then okay, next slide.
There's a probable mechanism for cause of
No,
death
no,
with
I will leave it
opposite.
to Dr. Dhanlakshmi. Madam wants to proceed relating to this. Dhanlakshmi, please.
I mean, I just want to know why you have put this slide in this case. This one.
Just to show the normal proliferation of cells from embryonic stem cells to different lineages. Among this, when there is iron deficiency anemia, the progenitor cells are more committed towards the megakaryocytic. That's the reason for a platelet proliferation instead of erythroid proliferation.
Okay, you just actually shown this diagram to tell the mechanism of
Yes.
thrombocytosis in iron deficiency anemia.
Yes. Yes.
Okay. Nothing much, madam. Actually, he's nothing much to tell about this flow chart.
Okay.
Okay.
Continue, Rishi. Any more slides?
Yes, just a so final diagnosis of the patient was
No, this is not the final diagnosis. Give a complete diagnosis. You are fully focused only on the thrombocytosis. You are a physician. Give a complete diagnosis.
reactive thrombocytosis secondary to iron deficiency and vitamin B12 deficiency with peripheral nerve involvement.
Peripheral, you spoke of dorsal column. Now we are telling peripheral nerve involvement. I still have a lot of questions for you. You are not bringing diabetes into the picture at all. Can't the diabetes be the reason for a peripheral neuropathy? And I still don't understand how is it that you have the ankle jerk, but you have a plantar that is flexor, bilateral plantar flexor. If you are going to talk of dorsal column, would you like to say that the patient has any early subacute combined degeneration of the spinal cord? Nothing, none of these are found mentioned. I do agree, it's more for the hematological part, but considering the physician-based diagnosis, I want a complete diagnosis. Yes, I've given you the clues. Give one complete diagnosis, and with that, we can close the session. On the basis of the chronological order of the patient's complaints and presentation, give a complete diagnosis.
Reactive thrombocytosis,
Diabetes mellitus.
Diabetes mellitus, and systemic hypertension with the posterior column involvement.
No, that's what I want to know. Is it a part of a subacute combined degeneration? Because you're talking of a B12 deficiency also.
Yes, ma'am.
Or is it just a peripheral neuropathy on account of the diabetes?
It's a posterior column involvement secondary to a B12 deficiency.
Then iron deficiency and reactive thrombocytosis. What are the other components of subacute combined degeneration of the spinal cord?
Posterior column involvement and
postgraduate students should present in its full format, and you should read everything relating to that. What are the other clinical signs that you can have in a patient with vitamin B12 deficiency?
glossitis and
you can have a mild splenomegaly, you can have pancytopenia, you can have hemolysis because they are distorted RBCs, you can have even jaundice, a mild jaundice. All this can be present as part of vitamin B12 deficiency. You can have even knuckle hyperpigmentation sometimes. So there are so many things that you could have retrospectively seen in this patient. From the neurological angle, history point of view, clinical examination, so that the examination is thorough, it is holistic. That is very important. I think for future, this should be a message for students. It's not only about for the reference, it is to see the patient as a whole. Maybe we can stop at this level, Saravanan. Anything more?
What is the patient's fundus examination, Rishi?
Fundus is left out, I know. Fundus, what about the fundus?
actually, we did not do a fundus examination.
That doesn't matter whether diabetic or not, but your case is referred to thrombocytosis. You should look into the fundus. You should have looked into the fundus. So make it as a habit as a postgraduate. I used to tell my postgraduates, whether it's a fever patient or joint pain, doesn't matter, whatever the problem, carry your fundoscope, examine all the patient's fundoscope. It's a must. That's a basic instrument you're supposed to carry. See all the patients, whether going to finding or not, expecting finding or not, doesn't matter. Just go and see all the patients.
No, here it
Right.
is from the diabetes point of view, as well as from the anemia point of view, and from
And
the thrombocytosis point of view. You can have findings in the fundus, and it's a
Yes.
golden opportunity. I think that is grossly missed.
So, okay, Rishi,
Yes, sir.
yeah, let this be platform for you to learning curve. Don't get feel anything wrongly. We are all firing you only to make you to understand what we stand and how much we have to go. It's only platform for us to learn. Okay. So take this as a positive note and try to go ahead with your presentation. Okay. Definitely you would have learned a lot of points where all the areas you missed out and where all the areas you want to improve. It's a high platform. It's a good platform for you to make your all mistakes. You're going to make all these mistakes in the examination. What would have happened? You know the results, right? So you don't make the same mistake in the examination. That's the basic idea of this platform. Clear?
Yes.
Yeah, bit bold. Postgraduate, we should talk boldly. Okay,
Okay.
clear.
Yes, sir.
Yeah, so don't get feel anything wrongly. It's all the areas where you can. You see, every one of us face the same problem and come to this level. So when you're making your noise a bit louder, doesn't mean that we know everything from the day one onwards. We're all everything is learning curve, right? It's a continuous process. Understand?
Okay, sir.
Rishi, are you there?
Yes, sir. Yes, sir.
Your volume has gone down.
No,
Why do you
sir.
want to reduce your volume of talk? Volume of talk.
10:45, Saravanan.
Yeah. Okay. Okay. Anyhow, Dr. Dhanlakshmi, I want to add any other points? Or madam?
No, sir. No.
Shall we
No,
conclude, madam?
Saravanan. I think we can wind up.
Really, thank you, Dr. Geeta, madam,
you.
and
Thank you, Dhanlakshmi. Thanks a lot.
Thank you, madam. Thank you, madam.
Saravanan,
Thank you,
thank
sir.
you.
Yeah,
Rishi,
thank you,
thank
madam.
you.
Thank you, ma'am.
As
Thank you.
sir has told,
Thank you,
yes, please learn well. This is an opportunity to know that you can improve on this.
Yeah.
Yes, ma'am.
And if Bharati
Thank
Raja
you.
is available, thank you, Bharati Raja.
Yeah.
Thank you, everybody.
Thank you, Vardarajan. Thank you, and good night, all of you. Good night.
Good night.
Thank you, sir. Thank you, ma'am.
Thank you, ma'am. Thank you very much. Thank you.